The moderators are Dr. J N Pande and Dr. Rajkumar. Dr. J N Pande is former professor and head Department of Medicine, All India Institute of Medical Sciences, New Delhi, and he's also a emeritus professor, National Academy of Medical Sciences. He is a recipient of Sri Om Prakash Bhasin Foundation Award in Health and Technology. Dr. Pande. Our second moderator is Dr. Rajkumar. Dr. Rajkumar is Present Director of All India Institute of Medical Sciences, Rishikesh. He is MS, MCH, FRCS, MRCS, PhD and FAMS. He has established the super specialty of pediatric and onco-neurosurgery and trauma center at SDPJIMS, Lucknow. He has around 400 indexed publications in national and international journals and several awarded research projects. He is a reviewer and editorial board member of several prestigious journals, a member and office bearer of several prestigious professional societies. He is a visiting faculty at several international universities and a recipient of more than a dozen of prestigious awards. I invite both the moderators. Dr. Pande.
पटियाला में मिल चुके हैं ग्रेट टू सी Is it to me now?
Yes, sir.
Okay. Please try to mobilize more people inside.
Yes, we are doing it.
Well, let us move ahead. And Professor Pande has already been introduced. And I would request Professor Pande to deal on current status and scope of personalized medicine. Professor Pande is a renowned physician, as you have already said, committed and dedicated teacher, former head of Department of Medicine of All India Institute, postgraduated from All India Institute, and I don't think much is required. These are his designations, and it is self-revealing as to how profound, knowledgeable person he is. Professor Pande, sir.
Dr. Rajkumar, Director, All India Institute of Medical Sciences, Rishikesh. It's been nice to meet you here after a brief acquaintance that we had at the NAMS Symposium in Patiala. Friends, I have been asked to speak on a topic on which I am not very knowledgeable. Professor Bajaj, who has been the patron of the National Academy of Medical Sciences for many decades, asked me about a week ago to participate in this symposium. And the topic, he said, was personalized medicine. I didn't know what this personalized medicine was at that time. So whatever I have learned is as a result of searching the literature for the last 7 days, which is good because participating in this symposium are also 2 medical students, Arnav and Arnav. And one of them has joined this medical college only 2 months ago. The theme of the conference is shared learning, and our students have much to teach us because as we are growing old, the number of neurons, Dr. Rajkumar, you would appreciate, is going down. And our cognitive capacities are going down, whereas the youngsters who will be running the future generation are bubbling with ideas. So I'm extremely happy that the organizers have chosen to have medical students participate in this affair. When I was asked to talk on personalized medicine, a thought occurred to me. Personalized medicine, what is it? Is it caring for the VIPs and giving them personalized care? Well, that's not what it is. Then what is it? Medicine which is tailored for a particular individual who is your patient. Well, we have always done that. As an undergraduate, 1958, and for decades before that, we were taught that you take a history, and in that there is a personal history, socio-economic history, family history, which gives you a whole lot of information which can be used in making diagnosis and giving treatment and tailoring it to that individual's needs. That being said, advances in medicine occurred. It was found that there are people who have a certain disease and who are prescribed a certain treatment, but they respond differently. Some get better, some get worse, and some get side effects. And there is a whole lot of inter-individual variation amongst the patients with the same kind of disease. Further, same kind of disease causes rather different kinds of manifestations in different individuals. This is also something which as clinicians we have to learn, and that is why medicine is so fascinating, that no two patients are alike. It has been said that the practice of medicine can be improved by visiting the Toyota factory. I'm sure some of you may have read very interesting articles which appeared in the New England Journal of Medicine. And in the US, they sent their physicians to see the functioning of the Toyota car factory, to streamline everything, to do it in a way that time is not wasted and the medicine becomes cost effective. That is the most impersonalized form of medicine that you can think of. Nevertheless, personalized medicine is also a concept which has seen enormous amount of progress during the last 5 years as a result of enormous amount of research which is being conducted in developed countries and also in India and other developing countries where a whole lot of talent exists. I'm going to go through some of the slides which I have prepared. Most of them have been downloaded from the internet, therefore it won't be very interesting for you. But I would start off by saying that long back, I was interested in pulmonary medicine and tuberculosis. And it was always said, some people, when exposed to TB germs, they develop tuberculosis. Others don't. They are able to confine the organisms by their defense mechanism, isolate them, and never develop disease for the rest of their life. It was said there is a variation in genetic susceptibility. Disease, all diseases are caused as a result of an interaction between genes and environment. And therefore, it was natural to think that there is a genetic susceptibility to tuberculosis. 1982, with one of my colleagues, we published a series of articles which showed that a certain HLA type DR2 was associated with increased susceptibility to tuberculosis. This is something which is well established now over the last 30 years. Much more refined techniques are now available for genotyping. 2003, we sequenced the entire human genome. That's 11 years ago. Personalized medicine is defined as medicine for purposes of diagnosis as well as treatment and prognostication using an individual's genetic information apart from other information which is routinely gathered by the clinicians. And also by looking at the environmental interaction between the genes and the environment. When I was asked to talk on this subject, I said, I don't know anything much about genetics, but nevertheless, as an undergraduate, I had an exposure to persons who were knowledgeable in genetics. And they talked about it, and it was something which had already come up. It is in the last 5 years that the explosion has taken place in the information. But I would like to point out that there are only a handful of examples where personalized medicine in the real sense, that is using the genetic information of the individual and the genetic information from the tumor, has been utilized in diagnosis and management. Today, the maximum application of personalized medicine lies in the field of oncology, where it is now appreciated that the tumors, the malignancies, are heterogeneous. When you talk of acute myeloid leukemia, you are talking of 12 different diseases. When you talk of non-small cell carcinoma of the lung, again, you are talking of at least a dozen different diseases. These dozen different diseases are identified by the genetic mutations which have taken place in the tumor and which are responsible for its aggressive behavior or a rather quiet behavior. Yesterday, there was a conference on the internet. I don't know whether you looked at it, in Kuala Lumpur. And the topic of discussion was non-small cell carcinoma of the lung. There were 12 experts from USA, UK, and other countries who deliberated on the type of mutations which occur, particularly in the non-small cell carcinoma of the lung, and how this information could be utilized for diagnosis and for development of monoclonal antibodies, and which could curtail the aggressive behavior of this tumor. In oncology, all of you are familiar with the story of Herceptin, human endothelial epithelial receptor, which plays an important role in the pathogenesis, progression, and aggressive behavior of the breast cancers which show this particular mutation. It was in 2008 that a test was developed to demonstrate this mutation. It was a kit-based technology. And also antibodies to take care of this aggressive behavior. Say about 15 to 20% of women with breast cancer have a very aggressive course. And the usual form of chemotherapy, which was administered, and the hormone therapy and the radiotherapy were not effective. But the availability of this particular therapeutic approach revolutionized the management of breast cancer, which was HER2 positive. Since 2008, 6 years have passed. There has been a lot of debate whether indeed, taking stock of the whole situation over the last 8 years, has it really improved the lot of those who have breast cancer? Thousands of other mutations have been identified with the availability of the genome-wide studies. And the significance of those mutations in breast cancer is unknown. You have the familial breast cancer and ovarian cancer, in which the BRCA1, BRCA2 is positive. And one can do these estimations. Unfortunately, it is a very complex and involved subject. There are legal issues, there are ethical issues, and there are intellectual property right issues. For example, the company which gives you the report of BRCA1, BRCA2 positivity in breast cancer has patented the technology and has a monopoly, and it charges an exorbitant amount of money to people, patients who want this to be done. It's almost unaffordable in a country like India. It's also true for HER2 receptor, but perhaps not that much, because HER2 receptor treatment has really made a major difference in the management of breast cancer. I'm just talking about breast cancer. A little bit I said about the non-small cell carcinoma of the lung. Incidentally, only 4% of the people who have non-small cell carcinoma of the lung have the kind of mutations which are amenable to the antibodies therapy. So it's a very small number. And the cost involved is fairly large. The American College of Cardiologists had a meeting 2011. And the theme was that everybody is talking of personalized medicine, and what are we doing as cardiologists? So the examples came up. They said, look, the treatment of patients with acute coronary syndrome with the use of anticoagulants has been revolutionized. Could I have the lights, please? Because I don't know whether I want to use any of these lights. I've got 52 of them. So maybe you can have the lights on. So one of the examples was warfarin. Of the patients who come to the emergency room with a serious adverse drug reaction, the most important is over-anticoagulation with warfarin, and the second is hypoglycemia caused by hypoglycemic agents in diabetics. two major examples. They are responsible for almost half of the total number of adverse drug reactions which occur in any part of the world. So, obviously, it was of great interest to find out whether the coumarin or the warfarin therapy could be individualized. And the International Warfarin Association held several meetings. And they deliberated as to what should be the correct dose and the dosing schedule for warfarin in patients with acute coronary syndrome. The net result was rather complicated because they developed a website where you had to feed in the information about the age of the individual, the gender of the individual, whether this is the first time the medication is to be given, whether the patient is taking amiodarone and a host of other drugs which interfere with the metabolism of warfarin, and certain information about the diet. And then you put in this information and out came the schedule which was recommended. Well, obviously, it's a rather lengthy process, and although randomized controlled clinical trials using the results of the International Warfarin Association recommendations did show that the incidence of adverse reactions declined, but the effect was not that noticeable in certain other studies. And therefore, there remains a question mark whether just monitoring the INR as we do as clinicians currently and proceeding in a cautious manner is adequate, or do we need to do these two enzymes? One is the vitamin K inhibitor, and the other one is something which I forget, but I could show you in this slide. Which one? Cytochrome 450, some variation of that, that is 2CY or something which I don't remember. Yeah, the cytochrome P450 is basically the controller of all the metabolic processes of the drugs and many other carcinogens which are there in the environment. I think I had a publication on acetylation status and its relationship with oncogenesis and adverse reaction to the drugs. Long back I published it in the the publication which comes from All India Institute of National Medical Journal of India, NMJ. It's a pretty good journal. If you've not read it, I think you should. Those mutations can be checked with the help of a kit, and then you can decide whether or not the dose will be standard dose or higher dose or lower dose, and this way you may be able to reduce the adverse reactions. I'm talking of the proceedings of the American College of Cardiologists, 2011. Then they said, look, we got a lot of evidence about clopidogrel. That clopidogrel is a prodrug. It is metabolized in its active form, and this metabolism depends on the presence or absence of certain enzymes which activate this. Now, those who lack this capacity to activate the prodrug clopidogrel into the active constituent do badly if they are given antiplatelet medication with clopidogrel after acute coronary syndrome. Randomized controlled clinical trial. They indeed show that the frequency of the blockage of the stent and acute coronary events was higher in those who had that kind of genetic constitution. Again, this is a kit-based technology. It can be done. It has been recommended by some people, published in the journals. The consensus at the American College of Cardiology meeting was that it is not all that helpful. We need more data. There is no convincing evidence that it really works. The consensus amongst many of the cardiologists has been, who have used these two examples for the prescription of personalized medicine, is that it is a research tool. It is not yet ready for clinical application. Well, there are many other examples where it has indeed worked and it is ready for clinical use. As a matter of fact, it must now be used if you do not wish to enter into legal problems. The FDA, for example, has changed the labeling recommendations of something like 30 to 40 drugs. That includes warfarin as well, for that reason. They say that, well, you need to check this and then only decide on the dosage. Very important drug which was used in the treatment of HIV infection. That is abacavir. It was a good drug. It is still a good drug, but it went into disrepute because it caused very serious adverse hypersensitivity reactions of the skin, and they were sometimes fatal. Then it was found that this abacavir toxicity could be predicted by undertaking a kit-based genetic test. And since then, it is mandatory for this test to be carried out and its result be taken into account when you prescribe abacavir. So this is something which has entered in clinical practice. This may not be so in the case of carbamazepine. The maximum number of skin reactions, the toxic epidermal necrolysis and Stevens-Johnson syndrome, occur as a result of the use of carbamazepine and certain other drugs which are used, for example, lamotrigine. And again, a certain genetic abnormality has been demonstrated. Actually, it is an HLA-based test which tells you whether the person is going to have hypersensitivity reaction to carbamazepine. And however, it is not yet mandatory. It is included in the labeling by the FDA. So how many examples I have given in the field of oncology, cancer medicine? I think today you can't practice in an academic cancer center without this information, knowledge and technology. This has come up, it is going to be there, and it is going to bring about remarkable changes in the way we diagnose cancers and treat them. However, in certain other areas that we have discussed briefly, the toxic reactions to the medications, infectious diseases, immunological disorders, a whole lot of work still needs to be done before we can conclude that the use of these kinds of tests and the kind of information they provide improves clinical care. Ladies and gentlemen, in a country like India, where you have acute severe malnutrition, where children are stunted in growth, there's so much of malnutrition. In a country where you can't treat tuberculosis, you came up with the idea of revised National Tuberculosis Control Program, supervised DOTS strategy. You had the concept of one or two regimens which are appropriate for all patients with tuberculosis, pulmonary and extrapulmonary. And in spite of that, the performance of the program was less than satisfactory. In that country, you want to practice personalized medicine, where you expect 10 years from now, this is going to happen. The patient is going to come with his or her genome-wide scan on a chip. And he will say, doctor, this is it. You kindly see before you prescribe any medicine to me or before you make any diagnosis and order diagnostic tests. I am giving you this information. It will cost 5 years hence only $700. 5 years ago, it cost $50,000. So, things are going to change. Because the technology is advancing at an enormous pace. Will the practice of medicine also advance at the same pace? Will we be able to do it in this country? Yes, we can. If we can, amongst the elite countries who have sent a satellite to the Mars, amongst the 9 countries in the world, why not? So, ladies and gentlemen, this is what I had to say. I have spoken briefly. I have not burdened you with a whole lot of material which I had on the slides. But I think this way I could communicate better to you what I wanted to say. I again thank you for calling me and inviting me to this holy place. Thank you.